I'm going to introduce the first speaker. The speaker is Horace. He's a man with golden hands. He's an excellent surgeon. He was in Rouen, France, and recently moved to Bordeaux, so he's getting closer to Spain. And he's going to talk about the point of view of doing surgery for, and that's important, we may discuss this after, deep endometriosis. The floor is yours.
Thank you very much. Mr. Chairman, ladies and gentlemen, it's my absolute pleasure to be invited at this prestigious meeting with more than 1,000 participants to speak about the surgery against the ART. However, pleading pro-surgery at the EV Congress, it's a task for fearless guys or madmen. However, I will try to argue why a well-done surgical treatment prior to ART in a majority of patients with deep endometriosis and pregnancy wish may be a valuable option. And in my presentation, I will focus on colorectal deep endometriosis. Why? Because it is the most frequent of severe form of deep endometriosis. And we have a myriad of publications which allow us to draw some conclusions. So, my lecture does not concern endometrioma surgery. I want to emphasize that I was among the first surgeons who observed that the excision of endometriomas is harmful for the ovarian reserve. And as back as 2009, I completely stopped to perform cystectomy in endometriomas in women who intend to get pregnant. So I won't focus on this topic, where I agree with you that the surgery may not be useful. So I will focus on this particular situation that you know very, very well, where a young woman, let's say 30-year-old nullipara, stops the pill to get pregnant. And after a couple of months, she has some symptoms which prompt the diagnosis of deep endometriosis infiltrating the rectum. So the general practitioner refers her to a physician, and the physician too frequently asks her, what is your priority? Relieving pain or getting pregnant? And the answer, of course, is getting pregnant, because the patient had the time to look at the internet and to see that the endometriosis may lead to infertility. So she's scared by the possibility to be infertile. So the doctor will say, well, you need first one or several IVF, and then we'll see. But I think that the question itself is wrong, because it suggests that the two goals, to relieve pain and to get pregnant, cannot be accomplished at the same time. And this is completely wrong. Furthermore, she stopped the pill a couple of months ago, so we have no evidence that she's actually infertile. So the question is, does she need an IVF? However, my colleague who saw the patient bases his conviction on guidelines, on ESHRE guidelines, and everybody knows that we have no randomized controlled trial comparing the surgery to IVF, so no definitive conclusion can be provided favorable to the surgery or to the IVF. That's why the conclusion of the ESHRE group was that the effectiveness of surgical excision of deep endometriosis before the treatment or with assisted reproductive technologies is not well established to be useful. So it is not routinely recommended. However, the group emphasized that women with deep endometriosis often suffer from pain requiring surgical treatment. So, surgery would a priori not improve fertility rates when the IVF is mandatory. But is it really mandatory? As regards the recommendation to take care about the pain of patients, I do not completely agree. Because, in my opinion, the symptoms are much more important than the pain. Because in deep endometriosis, you have numerous symptoms which are more important than the pelvic pain. For example, the deep dyspareunia. Young women cannot have sexual intercourse. This is a major symptom, however, it is not a pelvic pain. Dysuria. Dysuria for me it's a catastrophic symptom because it means that deep endometriosis involves the splanchnic nerves. So there is a huge risk that this young woman requires self-catheterization for the whole life. It is not pain. Dysuria is not painful. Bloating. Bloating is not a painful symptom. However, it may be the consequence of huge endometriosis involving the colon, and there is an actual risk of bowel occlusion. Every year I manage several patients with subocclusion and also with occlusion which had a stoma elsewhere. It is not a rare symptom. Silent kidney. When you have deep endometriosis involving the ureter, the patient may lose the kidney without having pain. Kidney atrophy is not painful, so you have not to expect to have pain because you may find a silent kidney. Sacral roots or sciatic pain. This is not a pelvic pain. It's a pain in the buttock and in the leg. So it's not need to refer the patient for osteopathy or kinesiotherapy. There is deep endometriosis which irritates or infiltrates the sacral roots. The surgery is most challenging, so it's not time to delay it. But let's say that our patient is just a little painful and she wants to get pregnant. So the question is what she can expect depending on each strategy, surgery or IVF. And we have some evidence to answer her what is the probability of pregnancy if she has IVF or surgery. And let's start by IVF. So if we leave the endometriosis behind and we refer her for IVF, she can expect up to 68% of pregnancies. And this data comes from an article, a study of Marcos Ballester, a friend of me in Paris. He prospectively followed up 75 patients with colorectal endometriosis who underwent IVF. And he observed that 43 of them conceived, and he estimated that if all the patients had 3 IVF cycles, the pregnancy rate would have reached 68%. So 68% is the best we have seen. Now let's see what result we can expect if we propose the surgery. So the pregnancy rate is not up to 71% as written here, but 81%. So here you have a study, a review of the literature reported by Nicolao Berlanda from Milano, and the authors pulled together several series of patients with a deep endometriosis, and they concluded that if you perform the surgery, you can expect 24% of natural conception which are due to the surgery itself. And now I will present you some results from our database because since 2009, all the patients I have managed for endometriosis have been enrolled in a prospective database. And I have a clinical researcher who is paid to only manage this database and to send to patients follow-up questionnaires 1, 3, 5, 7, and 9 years after the surgery. So I had a good idea about what has happened with my patients. And here you have a study published in 2015 in Human Reproduction where I tried to see whether or not performing the colorectal surgery in patients with endometriomas impairs the results in terms of pregnancy. So all the patients in this area had ovarian endometriomas, which were treated by ablation, vaporization using plasma energy, so no cystectomy in these areas, and half of them had colorectal endometriosis, which was cured. And I observed that the probability to get pregnant was 74% 3 years after the surgery, and I actually saw 66% of pregnancy rate, and the majority of them were spontaneous conceptions. And if you look at the Kaplan-Meier survival curve, you can see that performing the colorectal surgery, in addition to the ovarian surgery, did not change the probability of postoperative pregnancy. Some patients from Rouen, from my center, were pulled to some patients from Tenon Hospital in Paris, and Marcos Ballester performed a retrospective study to check the results of the IVF in patients with previous colorectal surgery. And he observed pregnancy rate 60% in patients with operated colorectal endometriosis. And he estimated 78% of pregnancy rate if all the patient has free IVF. And he observed that the conservative surgery, meaning that we try to avoid the segmental colorectal resection and we try to perform a conservative surgery by shaving or disc excision, so limited surgery on the bowel, as well as fast ART management, or the two factors which increased the rate of pregnancies. And here is my major study. It's the first and the unique randomized trial comparing two surgeries for large colorectal endometriosis. So there are patients with symptomatic colorectal endometriosis, large colorectal endometriosis, which are randomized between segmental resection of the rectum and shaving or disc excision, meaning conservative surgery. So the main outcome was not the fertility, but as the trial was randomized, the patient were carefully followed up for years. And now we have 6 years of follow-up. And we could observe that 4 years after the surgery, after the primary surgery, 81% of patients were pregnant, with a majority of pregnancies spontaneous, natural conception. And if you look at only infertile patients with preoperative conception failure for longer than 12 months, you observe that these patients were pregnant in 74% of cases, and again, in infertile patients, the surgery allowed a majority of conceptions spontaneously. And I try also to understand whether or not, after the surgery, if I refer the patient directly to the IVF, the conception is faster. Because, in daily practice, we can say, the patient should be pregnant quickly, so we refer her for IVF. What you observe that at the end of the surgery, when I said I used the endometriosis fertility index, and each time I said to the patient, go to spontaneous conception, the patient had the probability to be pregnant earlier than the patient who were referred to IVF. Why? Because to have an IVF, you have to encounter the physician. There is a preoperative, the pre-IVF consultation. So there are some delays which postpone the IVF, and you know that the first IVF is not always successful. So we observe that spontaneous conception is faster in patients where the surgeon said you can try a spontaneous conception. Now, let's compare the situation where the patient is referred to the primary IVF versus primary surgery in studies where there were two arms of patients with each one of these strategies. And we have such studies, and the most beautiful is The best is that of Paolo Bianchi from Sao Paulo. It was published 10 years ago. And Paolo Bianchi enrolled patients with rectovaginal endometriosis, and the patient choose themselves whether or not they want to have a surgery versus IVF. And it's a pity that he did not randomize the patient, because I think that the debate would have been closed today. So the patient choose between IVF and surgery, and this is a confounding factor because we do not know why they choose the surgery versus IVF. We do not know whether or not they were more severe in the surgical arm or in the IVF arm. But at the end of the trial, enrolling only patients with surgery and IVF versus patients with IVF without surgery, Paolo Bianchi observed that the pregnancy rate after IVF was better when the surgery preceded IVF. However, I called him and I asked him to look at his database and to add the patient, to identify the patients who had a spontaneous conception after the surgery or before the IVF, and these patients were excluded from the study. And he checks the data and he found that the spontaneous pregnancy rate in his database, outside the article published in 2009, was 8% in the arm IVF, which is normal because stage 4 endometriosis, the probability of spontaneous pregnancy is about 8 to 10%, and 21% after the surgery, meaning that if we pull together the patients with IVF, surgery IVF, and surgery spontaneous conception, we may see 29% of pregnancies if the patient chooses IVF versus 51% if the patient chooses surgery followed by IVF. The difference is significant. And now another study where we pulled together the patients from Paris and from my center in Rouen, and we tried to perform a propensity score. It's a kind of a false randomization because retrospectively you choose the patient who had similar characteristics, and we compared surgery versus IVF, surgery and IVF versus IVF, and we observed that surgery and IVF provides better results than IVF alone. Now, you will see, okay, you perform the surgery, but the surgery of deep endometriosis is complicated, so you may have complications in young women. I agree with you. The question is whether or not the risk of postoperative complications may balance the advantage of postoperative spontaneous conception. And if you look at the literature, you can see that the rate of postoperative complication is not as scary as it seems. Because the rectovaginal fistula may occur in 2 to 3%, but we can repair it. The leakage, less than 1%. Ureteral fistula, 1%. So all these complications may be managed within 6 months to 1 year. And they concern only a minority of patients. And this is always my experience in my own database, because to date I have managed more than 850 patients with colorectal endometriosis, and the rate of rectovaginal fistula and leakage is inferior to 3%. And these results should be put in the mirror with 65, 71, 81% of pregnancies after the surgery. Furthermore, the patient had the endometriosis removed. And we also try to understand whether or not the patients with postoperative complications have the fertility definitively impaired. And we pull together patients from my center, from Lille Center, and from Paris, and we observed that in 48 women with severe complications requiring a second surgery, the pregnancy rate 5 to 6 years after the surgery was 42%, and the majority of them were spontaneous. So I think that the risk of complication, postoperative complication, does not balance the benefit of the surgery on spontaneous conception, and maybe on the conception by IVF after the surgery. Now, let's turn the situation on the other side. Let's ask ourselves if repeated IVF procedures in patients with unoperated endometriosis are always safe. We have a paper in revision in review in human reproduction, where I enrolled 43 patients. I saw in my consultation during 1 year, and all the patients had at least 2 MRI without surgery between the 2 MRI. And the 2 MRI should have at least 1 year apart. And I checked whether or not the patient had IVF or tried to get pregnant, and I observed that 40% of patients who were not in amenorrhea during the period between the 2 MRI had an obvious progression of the nodule, of the colorectal nodule. And when I say obvious progression, to state the progression, we choose to have an increase of at least 1 centimeter of the nodule, meaning that in some patients the nodule increased by 50%. So 40% of patients without amenorrhea and rectovaginal nodule, rectal nodule, may see their nodule growing. And what does it change? But everything may change, because performing the surgery later in bigger nodule may change completely the functional outcomes and the result of the surgery. Expecting the surgery, the patients may have occlusion, kidney loss, self-catheterization. Performing the surgery on very big nodule infiltrating the vagina dramatically increase the risk of rectovaginal fistula, and the nerve infiltration is followed by neuropathic pain, which are not solved by the surgery. So, good surgeons can do challenging surgery. We can remove the endometriosis. However, the price to pay by the patient in terms of functional outcomes and complications rate is not the same. Sometimes, when I manage the patients with big, deep endometriosis with previous IVF, I ask myself how my colleague who performed the IVF could reach the ovary with the needle without injuring the rectum. So it is in some cases, I do not understand how you can do to reach the follicles. Because the pelvis is frozen and the rectum is between the vagina and the ovaries. And just to recall the case of one patient, a 26-year nullipara, 6 unsuccessful IVF prior the surgery, 1 peritonitis open surgery, 1 homoperitoneum following the punction, 2nd laparotomy, and then I had to perform a very challenging surgery in a subocclusion of the bowel. The result of the surgery was not good at all. Now, the take-home message. So, I'm not a crazy man. I try to be a fair scientist. I know that all of you here, you know many patients whose fertility was dramatically destroyed by surgery. So I know that the data in the literature, which are reported by experienced team, are not the same you see in the daily real life. That's why I try to moderate my presentation, and the goal is to emphasize that there is no randomized trial to state that IVF should be done in deep endometriosis versus surgery. I try to emphasize that I agree we have a negative impact of the surgery of endometriomas on the fertility, on the ovarian reserve, but this does not concern the deep endometriosis surgery, that we have enough data to think that the total pregnancy rate is probably higher after deep endometriosis surgery with or without IVF than IVF alone, that natural pregnancy rate is definitively higher after the surgery, and of course there are some benefits in terms of pain, surgical outcomes, and reduction of health expenses. Now, what I expect, my final message for you is that if you see in consultation for infertility a patient with deep endometriosis, my advice is to perform a complete deep endometriosis assessment, MRI, endorectal ultrasound, CT scan, everything you need to understand the extent of this disease. To ask an advice to an experienced surgeon, an experienced deep endometriosis surgeon, in order to have a valuable advice about the feasibility of the surgery and the risk related to postponing of the surgery. Keep in mind that the patients with deep endometriosis are very heterogeneous, so you cannot provide guidelines, definitive guidelines. So it's a custom-made management. And don't forget, patients with deep endometriosis, there is a benefit to give them a continuous pill between 2 or 3 IVF procedures. They do not need to have periods, because the periods may lead to the growth of the nodule. And final message, try to do not push your luck too far with the IVF in unoperated patients in order to avoid complications. Thank you very much.